Thank you, Filippo. Thank you very much again for the invitation and the chance to discuss a little bit about these neuroendocrine tumors. These are my disclosures. So certainly we're all familiar with small cell lung cancer. This is an exceptionally lethal subtype of lung cancer. It accounts for about 13% of new diagnoses, but that varies a lot by geography based on smoking use. Majority of patients, about 2/3, will present with extensive stage disease, and this is a cancer that moves very quickly. Patients are symptomatic at diagnosis. The natural history is very unforgiving, but it's a cancer where we can make a big impact early on, and the delivery of standard platinum etoposide chemotherapy is very effective, at least initially. Response rates are very high, north of 60-70%, rapid clinical improvement. Patients will feel better predictably. This is one of the few cancers that we can treat a fairly ill patient in the hospital and help them get out of the hospital. And yet that benefit is transient, because just as predictable as the response is the relapse. Median progression-free survival historically with chemotherapy has been about 4 months. And remember, that starts from cycle 1, day 1 of chemotherapy. So most patients progressing either during or shortly after induction chemo. Survival had been limited about 8 to 10 months. And really our standard of care had been stagnant for 30 or 40 years. There have been dozens of clinical trials, phase 3 trials, that simply failed to improve overall survival. The first study to really do that was IMpower 133. This was a randomized phase 3 trial, double-blind, placebo-controlled, where all patients received standard carboplatin etoposide and a randomized 1-to-1 to receive concurrent and consolidation atezolizumab, the PD-L1 inhibitor. Primary endpoints of progression-free survival and overall survival. We saw that it met both of its endpoints. The addition of atezolizumab to chemotherapy led to a modest improvement in PFS, most importantly, an improvement in overall survival, with a boost from the median from 10.3 to 12.3 months. That's a hazard ratio of 0.76. These data were recently updated last year, and we see the difference at 18 months, really the same as the difference at 12 months, a modest improvement, but an improvement nonetheless, establishing a new standard of care. Atezolizumab with carboplatin etoposide was approved by the FDA in March 2019, approved by the EMA in September 2019 as a Category 1 preferred option. Again, the first advance to impact survival in small cell for over 40 years. This established chemoimmunotherapy as our standard of care for extensive stage small cell lung cancer, and that's been reinforced by multiple subsequent phase 3 trials. The next was CASPIAN, slightly different design. As you can see, this was a 3-armed study. This was an open-label trial. Other important differences: choice of platinum, carboplatin, or cisplatin. The control arm received up to 6 cycles, not 4 as in IMpower 133. PCI only in the control arm, not in both arms. These are, though, relatively minor differences, and the outcomes were really similar. When we look here, the curve's almost superimposable. The addition of durvalumab to platinum etoposide led to an improvement in overall survival. Here, hazard ratio 0.75, leading to its approval in both the US and the EMA. Other trials showing similar outcomes. EA 5161, led by Dr. Tiziana Leal, showed that the addition of nivolumab, a PD-1 inhibitor, improved survival. This is a randomized phase 2, not something with regulatory potential, but still showing similar benefit. And at ASCO this year, we saw the results from ASTRO 005. This was a randomized phase 3 trial looking at serplulimab, another PD-1 inhibitor added to carboplatin etoposide. And again, a modest improvement in PFS and an improvement in overall survival. Here, hazard ratio 0.63, an improvement in the median from 10.9 to 15.4 months, and a 1-year survival rate from 50 to 60%. Here we see these curves. These curves tend to split after about 3 or 4 months, about the start of maintenance, and we see that that separation persists over time. Still relatively immature, but certainly encouraging. Capstone 1, yet another phase 3 study showing a benefit. Adabrelumab, another PD-L1 inhibitor with platinum etoposide. Again, a modest improvement in both PFS and overall survival. When you add a checkpoint inhibitor to chemotherapy, you generally improve survival. However, not all the studies were positive. KEYNOTE 604, famously a negative trial, the addition of pembrolizumab not meeting its endpoint for survival, not leading to approval. But I think we agree that the trends here are very similar, and we know that famously they were 1 patient short of meeting that survival endpoint. And so maybe more statistical, the distribution of alpha in this study, but generally checkpoint inhibition with chemotherapy improving outcomes. We now have 2 FDA-approved options, atezolizumab and durvalumab, multiple other checkpoint inhibitors showing similar benefit, the addition of immunotherapy, improving outcomes, a welcome advance, but I think I speak for all of us when we say that there's still plenty of room to go. So that benefit being relatively modest, what else can we do? How else can we further improve outcomes? What about CTLA-4 inhibition? I know there are a lot of fans of CTLA-4 in small cell lung cancer, and it's true that there are a subset of patients that achieve long-term survival. If we look at Checkmate 032, this was a non-randomized cohort, but in blue, nivolumab, in orange here, nivolumab plus ipilimumab, these were heavily pretreated patients, and to think that 26% were alive at 2 years from enrollment really is quite impressive. And if you had treated one of these patients that's alive at 2 years, you would swear that nivo-ipi really holds a lot of promise in small cell. There's something to ipilimumab. Well, I don't want to discount that. The data don't back it up. We have from Checkmate 032 a randomized component that we don't talk about a lot, but patients here were randomized to nivo or nivo-ipi. And while the addition of ipilimumab did improve response rate, it did not improve median survival. It did not improve 2-year survival rate. What it did do was increase toxicity. And the randomized component simply did not back up that the addition of CTLA-4 to PD-1 really improving outcomes. And remember, in CASPIAN, we had an arm that had durva plus tremelimumab, another CTLA-4 inhibitor. And while durva plus chemotherapy improved survival, durva plus tremi did not. Now, the 2-3-year survival rates look like they'll probably catch up to durvalumab, but again, tremelimumab in this setting really only adding toxicity, seemingly holding back the response. And so today, CTLA-4 simply does not have any role in an unidentified and unselected population. Anecdotal evidence really should be put to the side. CTLA-4 really not backed up by the evidence. At ASCO this year, we saw data for tiragolumab. Tiragolumab, as we know, showed a lot of excitement in non-small cell lung cancer based on CITYSCAPE-2, where the addition of tiragolumab, an anti-TIGIT antibody, to atezolizumab, a PD-L1 inhibitor, significantly improved PFS and overall survival in a relatively small randomized phase 2, specifically in that PD-L1 high group. We know that PVR, which is the ligand for TIGIT, is highly expressed in small cell lung cancer, and so based on that preclinical rationale, Skyscraper-2 was launched. This was a large randomized phase 3 trial in frontline setting for small cell, where all patients received the IMpower 133 regimen of carboplatin, etoposide, and atezolizumab, and a randomized 1-to-1 to receive concurrent tiragolumab or placebo, followed by tiragolumab or placebo maintenance. Primary endpoints here, OS and PFS, and this study was very negative, really not showing any difference in progression-free survival or overall survival. While this is an immature analysis at survival, while this is not the final survival analysis, these curves will not separate. And so this will remain a negative trial, this drug not being developed in small cell lung cancer any further. I don't think this negates some of the data in non-small cell necessarily, but this clearly not the way to improve outcomes in small cell lung cancer. What we really need is to identify the patients who are getting benefit so we can ensure they get what they need, but better understand why not all patients are getting that same benefit. Biomarker work in small cells is very challenging. There's often very little tissue. Often patients are diagnosed by fine needle aspirate, which limits the amount of studies you can do and the types of studies you can do. Sometimes hard to look at architecture using a fine needle aspirate. Patients are often very ill, have comorbidities related to smoking, very symptomatic, and may not be able to go back and get more biopsies. So tissue can be challenging, but based on the work we have, we know that PD-L1 and tumor mutational burden, as flawed as they are, we heard from Dr. Mahjoubi, really no predicted benefit in small cell lung cancer. It's got to be something different in small cell. And most of the excitement now is based on expression of transcriptional regulators. Genomic analyses of small cell are very bland. You'll see loss of P53, you'll see loss of TP53 and RB, often amplification over expression of MYC, but otherwise relatively unremarkable. The expression of certain transcriptional regulators, though, do seem to correlate with different phenotypes and different biologic behaviors. Using 4 groups here, work done by Charlie Rudin, ASCL1, NeuroD1, PAL2F3, YAP1. This has been since modified by the group at MD Anderson, YAP1 really being replaced with an inflamed group. We applied these subset data to the IMpower 133 cohorts, and what we saw is that small cell lung cancer inflamed subtype was enriched for long-term survivors. And the SCLC, the PAL2F3 subtype was reduced representation in long-term survivors. However, we did see long-term survivors across all the groups. There are a lot of challenges with using these subtypes that we're still working through. Heterogeneity, plasticity, and going from one group to another. These are things we'll have to account for going forward, but still this represents sort of our best lead going forward as to what the useful translatable biomarkers will be for small cell lung cancer. In the meantime, chemoimmunotherapy remains the frontline standard. I think the next question to be answered is, will radiation further improve outcomes? The RAPTOR trial, LU007, is an extensive stage small cell study looking at consolidative thoracic radiation. This was not permitted in CASPIAN or IMpower 133, not because we didn't think this was effective, but because it was going to increase the heterogeneity of that population. Here in this study, all patients are receiving carboplatin etoposide and atezolizumab and are randomized to maintenance thoracic radiation or not, and all patients receive maintenance atezolizumab. This study is still enrolling. Hopefully we'll give some input, but perhaps we're building upon the synergy of radiation and immunotherapy, and we know that small cell lung cancer is a very radiosensitive tumor. NRG LU005 is a limited stage study. Limited stage small cell lung cancer represents about a third of cases. Our treatment intent there is curative. It's not necessarily our expectation, as we only cure about a third of patients with concurrent chemoradiation. This study, all patients are going to receive concurrent radiation and are randomized to concurrent atezolizumab with chemorads and atezo plus maintenance versus just standard chemoradiation. This study has met accrual as of this week, and hopefully will read out in the coming year. And the Adriatic study is another limited stage study looking at durvalumab alone or durvalumab plus tremelimumab versus placebo in the limited stage setting. This not concurrent, this really sequential in the consolidation setting modeled after the Pacific paradigm. We have other active drugs in small cell lung cancer. Lurbinectedin is a marine-derived transcription inhibitor synthesized from a Spanish sea squirt. The single-arm phase 2 study showed a response rate of 35%. Importantly, in the sensitive population, 45%, and in that resistant population, 22%, an area where we really don't have active drugs. Remember, topotecan, not approved in that resistant setting where its response rate is pretty close to zero. Based on the unmet need, lurbinectedin was approved by the FDA, accelerated approval in June 2020. The phase 3 Atlantis trial was reported last year. This was a randomized phase 3 study looking at standard second-line topotecan or CAV and randomization to lurbinectedin plus doxorubicin. This study did not improve survival. There was no difference here. We see those survival curves overlap. However, when we look at that study design, we can see it's not really the study we were looking for. This is not monotherapy with lurbinectedin. This is combination with lurbidox. Could the dox be preventing delivery of lurbinectedin, adding toxicity? And importantly, the dose of lurbinectedin is actually lower than we use as a single agent. We do know from some other studies that dose does seem to be important. So while this study was negative, perhaps there's a reason, and we will have other confirmatory studies that look a little more closely. Lurbinectedin clearly active in small cell lung cancer, a drug that I favor using in second-line setting. Using it earlier could potentially improve outcomes. There is a maintenance lurbinectedin strategy that's ongoing. That's the phase 3 IMforte study, where all patients receive standard carboplatin, etoposide, and atezolizumab, and are randomized to receive maintenance atezo or maintenance atezo plus lurbinectedin. Here's the study design. This based on some work from Luis Pazarez showing the combination of atezo and lurbinectedin, very effective in small cell. Other agents that are showing activity, liposomal irinotecan or now ERI in the single agent setting at 70 mg per meter squared, response rate 44%, with a phase 3 that is ongoing, hopefully reading out relatively soon versus straight second-line topotecan. This study does have breakthrough designation by the FDA. And Tarlatamab, or AMG 757, is a bispecific T-cell engager that targets DLL3 and CD3. We know that DLL3 is highly expressed on small cell cells. We've not found the perfect way to leverage that selective expression. Ravalpatuzumab tesirine, an antibody-drug conjugate, very toxic, and ultimately that drug not having a large enough therapeutic window to be active, but it doesn't negate the validity of the target, DLL3. The BiTE molecule here, AMG 757, is going to bind to DLL3 and then bring in T-cell by expressing CD3. In early work here presented by Dr. Taufik Wanakoko, we see response rate 20%. This is still an escalation, so that includes some fairly low doses. If we look at that swimmer's plot at the bottom right, we can see some of these are quite durable. treatment-related adverse events leading to discontinuation, only 5%, but the one to watch as the study grows in size is cytokine release syndrome. This occurred in almost half of the patients and is sort of an expected toxicity with its class of molecules. Fortunately, these were mostly grade 1, 2, only 2% grade 3, but as many of us know, cytokine release syndrome is one that can quickly escalate from stage 1 to grade 1 to grade 3, and so we'll see how this changes as the study matures and expands to other sites. We're clearly making progress in small cell lung cancer with 2 FDA-approved regimens, IMpower 133 and CASPIAN, other agents demonstrating similar benefit, hopefully approved in the near future. Our current trials are going bigger, adding empiric agents like radiation, like Lurbinectedin, but our long-term goal, and what we're hopefully talking about a few years from now, is to get smaller biomarker-defined studies with rational drug delivery. A quick pivot to large cell neuroendocrine carcinoma. This is a less common subtype of lung cancer that often straddles small cell and non-small cell. It has neuroendocrine morphology and the IHC markers that go with neuroendocrine, like synaptophysin, but it's not really consistent with carcinoid or small cell. This is not a small round blue cell tumor. Overall, it's about 2 to 3% of lung cancer. It's been described since the 90s. It's more aggressive than carcinoid. It's not quite as aggressive or as chemo-responsive as small cell, and a pretty wide range of outcomes with large cell neuroendocrine carcinoma. If we look at the genomics, I think they're very telling here. Large cell neuroendocrine is basically a diagnosis based on histology, based on phenotype under the microscope. If we look at the genomics, we see that there's very clear groups within this. There are mutations in P53, RB1, more than carcinoid, less than small cell. It falls in that spectrum of neuroendocrine tumors. About a third will have concurrent P53 and RB loss, just like small cell. And if we look at work done here by Dr. Natasha Reckman at Memorial, NGS of 45 samples with large cell neuroendocrine, we could see that some fit this non-small cell pattern of KRAS, STK11, KEAP1, and some fit this small cell pattern of P53, RB1, and MYC amplification. This was replicated by Dr. Julie George, genomic analysis of 60 large cell neuroendocrines, and this type 1 pattern that's more of a non-small cell. If we look at expression of transcriptional regulators, this seems to fall into the ASCL high group. And that P53RB, that more small cell genotype signature, really that DLL3 low, ASCL low group. So the optimal management of large cell neuroendocrine carcinoma is unclear. The options are really just to go with a non-small cell regimen or a small cell regimen. So it's going to be chemo immunotherapy, but the specific partners and agents you're using, I think, should ideally be defined by the genomics. And if it is a non-small cell group with a KRAS STK11 phenotype, I would favor a carboplatin-pembro, for example, whereas if it were more of a small cell RB P53 MYC signature, I would really favor a carbotopatezo. I think either are certainly reasonable. If there's a high proliferative index and you don't have necessarily the genomics handy, if your Ki67 is very high, might treat it more like a small cell. If it's fairly low, then I think treating it like a non-small cell is very appropriate. Either way, it's going to be chemo immunotherapy, but I think in the future, just like with small cell, that transcriptional data hopefully will guide therapy in this setting. And so a lot to cover, a lot of progress, certainly hope for the future. With that, I'll stop here and I'll pass things on. Thanks.
Thank you very much. So I will get going since I'm the last speaker. These are my disclosures, but I also want to acknowledge that there are mesothelioma experts whose slides I'm using in this presentation, Dr. Rafid Hassan, Dr. Joseph Friedberg, and Dr. Ansal. So I wanted to sort of do this presentation in the context of 2 of my patients. I want to be very honest that these patients I treated about more than 3 years ago, and so some of the data that has emerged was not applicable or was not available in these patients' management. Nonetheless, I thought that these patients make a point. So the first patient is a 73-year-old male patient who presented with shortness of breath and pretty significant chest wall pain. He had these CT scan findings, and a pleural biopsy demonstrated epithelioid mesothelioma. On other images, he was found to have multiple mediastinal lymph nodes enlarged. So before we get into the data set that sort of guides the management of this patient, I thought it would be worthwhile to discuss the epidemiology. This is not a common disease, particularly compared to lung cancer, about 2,500 to 3,000 cases per year in the US, and about 5,000 cases per year in Western Europe. What's interesting is there's a long latency period between the most common agent, that being asbestos, of up to 50 years. And therefore, generally these patients are elderly with the median age in the US of about 74 years. Because of regulations on asbestos use, the incidence did peak both in the US and Western Europe, but it is important to note that there continue to be countries that do use asbestos or don't have as many regulations on asbestos use, and so it's expected that mesothelioma will continue to be an issue in the coming years. And as would be expected, since to some extent this is a environmental or rather occupational hazard, there is a male-female ratio of 4:1. So treatment of patients like the patient I presented that was unresectable at the time of presentation clearly changed with this study presented by Dr. Vogelzang in 2003 that randomized patients to single-agent cisplatin versus combination chemotherapy. Chemotherapy had been used prior to this study. However, the benefit was quite modest, if any, and therefore this study truly changed the management of mesothelioma in that the combination did demonstrate superior activity both in terms of response rate, median overall survival, and time to progression. That the benefits were modest, but in the context of the fact that prior to this study, chemotherapy really had not shown any meaningful benefit, it was truly an advance. It's important to note there's this issue of cisplatin and carboplatin. This is not exactly randomized data, but data from an international extended access program, which demonstrated that the activity was fairly similar between cis and carboplatin. And so either agent can be utilized. Relevant because many of these are elderly patients and may not tolerate cisplatin. The next randomized study that did demonstrate a survival advantage was the MAPS trial conducted in France that randomized patients, and this included performance 2 patients, that randomized patients to platinum pemetrexed with or without bevacizumab. This was an open label study with maintenance bevacizumab following initial chemotherapy. This study did demonstrate a survival advantage with a 2-month improvement in median survival, and there was also an improvement in median progression-free survival. And benefit was seen to a large extent when you look at the forest plots across most subsets. Particularly, I would like to point out that benefit was observed more so in sarcomatoid histology, though it was also observed in epithelioid histology. However, one of the reasons why bevacizumab with platinum pemetrexed chemotherapy has not sort of been widely used is because of the fact that the combination was more toxic, particularly when it came to cardiovascular adverse events, with a significant increase in all-grade toxicity in terms of hypertension, thromboembolic events. And if you look at the rate of drug discontinuation, it was also higher in patients who received a bevacizumab, 24% versus 6%. And these cardiovascular toxicities are relevant again because this is an elderly population. So despite this positive study, platinum pemetrexed chemotherapy continued to be what was primarily used. So now, more recently, the thing that has clearly changed the landscape is Checkmate 743. This was the first evaluation in a randomized fashion of immunotherapy compared to the previous standard of platinum pemetrexed chemotherapy. This included performance status 0 and 1 patients. It was stratified according to histology, and the primary endpoint of the study was overall survival. Mind you, the Nivo-IPI schedule is similar to what is used in non-small cell lung cancer and not what is used in small cell lung cancer or melanoma patients. And this study showed survival advantage, and what I would say quite an impressive survival advantage with a hazard ratio of 0.73 that translated into a median improvement of survival of about 4 months. Now, there does appear to be a difference in efficacy based on histology. About 75% of the patients that were enrolled on the study had epithelioid histology, and though when you look at the numerically there was superiority with the combination, the IO combination, and the hazard ratio suggested a trend towards improved benefit. When you look at the confidence intervals, it did include 1, whereas there was a clear benefit in sarcomatoid histology patients. But this sort of difference in histology, in my mind, is further highlighted by when you look at progression-free survival. So when you look at the data, there's a clear inferior outcome in the initial part of the progression-free survival curves with the IO combination as compared to chemotherapy, and actually the median is slightly higher in patients who received chemotherapy combination. And when we look at the hazard ratio, it is exactly 1, highlighting the fact that in other tumor types, the immunotherapy combination appears to provide a significant benefit in possibly a minority of patients that drives the survival curve. And therefore, in a patient who is symptomatic, and particularly if the patient has epithelial histology, mind you, this is all patients together, when you look at the survival curves, it is possible that this progression-free survival difference may be even greater in epithelial histology, that one needs to be mindful that the progression-free survival may be, initially at least, higher in the IO combination patients. This is also shown in when you look at the forest plots, highlighting the issue of epithelioid and non-epithelial histology. But in this study, though benefit was observed, and this was retrospective subset analysis and needs to be viewed with a level of caution, the PD-L1 assay conducted suggested that the benefit was mainly restricted to PD-L1 positive patients. This PD-L1 assay was the DACO 28-8 assay, so not the DACO 22C3. And so that raises a question, at least in my mind, as to when you look at the epithelioid subset data as well as the PD-L1 data, should potentially PD-L1 testing be considered, particularly in the epithelioid histology patients, to try and understand at the present time who are the patients who should receive cytotoxic chemotherapy as the initial therapy as compared to this immunotherapy combination. The adverse events were what were expected, but important to note that the disease discontinuation rate because of treatment-related adverse events was somewhat greater in the Nivo-Ipi combination as compared to chemotherapy combination. And the toxicities, nonetheless, what was expected, colitis, skin toxicity, were more common in the Nivo-Ipi combination, whereas cytopenias and fatigue were more common with patients who received chemotherapy. Now, we tend to use more commonly, or chemotherapy IO is preferred in non-small cell lung cancer, and this is a combination that has been evaluated in 2 different studies. I'm presenting the ECOG trial published by Dr. Ford and colleagues. Dr. Ramalingam is the senior author on this study. Similar results observed also in another study from Australia led by Dr. Anna Novak. And what this study shows is that the chemo-IO combination also showed, mind you, a single-arm phase 2 study, but showed an impressive median overall survival of 20.5 months. And in this study, as one would expect with chemotherapy, the epithelioid subtype appeared to do better than the non-epithelioid subtype, with a median survival of 21 months in the epithelioid subtype. Based on these data, there is a randomized phase 3 study that I suspect is close to enrollment, that is randomizing patients to chemotherapy versus chemotherapy plus durvalumab with maintenance durvalumab after combination. So in the particular patient that I presented, this was, as I mentioned, I treated the patient about 3 years ago. At that time, we did not have the Nivo-Ipi data, and I treated the patient at that time with carboplatin, pemetrexed, bevacizumab. I utilized bevacizumab because the patient was clearly symptomatic, and I thought I would get a better response rate with the triplet regimen. Clearly, Nivo-Ipi now is a combination that can be considered in this patient. But again, based on the retrospective subset analysis, I wonder whether in a symptomatic epithelioid patient, whether chemotherapy still should be the preferred option, considering that there was a greater progression-free survival, better progression-free survival rather with cytotoxic chemotherapy. So what about second-line treatment? The data, when you look at cytotoxic chemotherapy, is quite minimal. The only data that is of benefit is with pemetrexed, but that was in patients who either did not get pemetrexed in the frontline setting or had a significant progression-free survival after initial platinum pemetrexed chemotherapy. But otherwise, all second-line cytotoxic agents have extremely poor or no response rates. And it is in this context that the confirmed trial definitely is an advance, where patients were randomized to nivolumab versus placebo, and this study showed both a progression-free survival and overall survival advantage. Modest benefit, nonetheless, a very meaningful benefit. Now, it is important to note that the type of patients enrolled in the confirmed trial was somewhat different than the standard sort of second-line patients. First of all, 70% of the patients had received 2 or more lines of therapy, and the median time since diagnosis was about 17 months. So this was, in my opinion, a select group of patients when you consider that the median progression-free survival with chemotherapy or IO combination is only about 5 to 6 months. So these are a different set of patients. Nonetheless, clearly this has now emerged the preferred second-line treatment, particularly in patients who have received chemotherapy. What about as first-line treatment? What about nivo-ipi in the second-line setting? This was a randomized phase 2 study. This was MAPS-2 that randomized patients who had received 1 or 2 prior lines of chemotherapy to nivolumab or nivolumab plus ipilimumab. And at least in this study, there did not appear to be a meaningful difference with nivo-ipi compared to nivo alone. Probably a slightly higher response rate compared to nivolumab alone, and maybe slightly higher 1-year survival rate, but not significantly better. And as expected, there was more toxicity. Sorry, I don't have the toxicity data, but there was more toxicity with the combination. So possibly in the second-line setting, nivo-ipi may not have a meaningful advantage over nivo alone. In my particular patient, after the patient progressed on the initial chemo bevacizumab, the patient was treated with pembrolizumab at that time on a compassionate use basis, but unfortunately progressed within 2 months and had an overall survival only of 10 months. So now there is, over the last year and a half, several immunotherapy agents the data has been presented, and now some have been approved. Checkmate 743 looked at nivo-ipi. There is data now on chemo and durvalumab in phase 2 study with expected data in phase 3. Confirm in the second-line setting has shown advantage with nivolumab. And quite interestingly, and I'm not sort of got into the depth of this because of lack of time, but there is interesting data emerging with CAR T cells, particularly against mesothelin antigen. And there are several institutions, particularly from Memorial Sloan Kettering, that are looking at this approach, and there may be another immunotherapy approach for at least some of the mesothelioma patients in the future. So going on to sort of more limited disease, this is a patient, a 65-year-old patient who presented with shortness of breath, had the findings of effusion and uptake in pleural-based nodules. Pleural biopsy again showed epithelioid mesothelioma, underwent mediastinoscopy, all lymph nodes were negative. And these are sort of the NCCN guidelines on patients that may be considered resectable, patients with stage 1 to 3A disease and with epithelioid histology. Usually surgery is not considered in patients with sarcomatoid histology. And there are 2 different approaches. One could consider a neoadjuvant chemo, platinum-based, platinum pemetrexed chemotherapy neoadjuvant treatment versus a direct surgical approach followed by post-operative treatment. What patients should be considered for surgery? Generally, patients who have disease limited to one chest cavity, only in patients with epithelioid histology. Lymph node positivity in itself may not exclude patients from surgical resection, but generally patients with low nodal volume. look at the labs, patients who have thrombocytosis or anemia generally don't have a good prognosis and are not generally considered for surgery. And of course, patients who have organ functions that can allow them to undergo such a thoracotomy. Now, there are different surgeries that can be performed. Extrapleural pneumonectomy is the most radical surgery that involves removal of lung, visceral pleura, pericardium, and diaphragm. But there are now more limited surgeries that are performed, including pleurectomy or extended pleurectomy decortication. Important principle about surgery is surgery generally is never the only treatment in this patient population. Now, when it comes to surgery, because it is such a complicated disease, involves elderly patients, what is the data regarding value of surgery? So there are two major data sets in this regard. One is a retrospective review looking at EPP versus pleurectomy with decortication. And what you can see is there doesn't appear to be a significant difference in survival. And so there was a big push for EPP some years ago, but as data has emerged, surgery is now much more tailored to the extent of disease. So if you have relatively limited disease, those patients could be offered pleurectomy decortication. But if the patient has more extensive disease, maybe those are the patients that should undergo EPP. However, EPP truly should be considered in high volume centers. But does surgery have a role in mesothelioma patients? And there's a small study called the MARS study conducted in UK, where they started off with 112 patients, but eventually randomized 50 patients to EPP, followed by hemothorax radiation versus chemotherapy alone, and found no difference in overall survival. There's a confirmatory phase 3 study that is ongoing that will truly answer the question, does surgery have a role in management of mesothelioma patients? What about radiation treatment? Generally considered for palliation, hemothorax adjuvant radiation is considered after EPP, but again, should be done at high volume centers. And there is data of hemithoracic adjuvant IMRT after lung sparing surgery. So not after EPP, but after lung sparing surgery. Is there data to support adjuvant radiation after EPP? If you look at multiple phase 2 studies, and this is aggregate data, there does appear to be somewhat better outcome in patients who received postoperative radiation as compared to patients who just got EPP. So this is sort of the basis of considering postoperative radiation. So in this particular patient, the patient did undergo extended pleurectomy with decortication and did receive postoperative IMRT after having received neoadjuvant chemotherapy. So because of the emphasis on immunotherapy, there has been somewhat of a lack of focus on targeted therapy approach. There are molecular alterations observed in mesothelioma. I mean, I would like to highlight the BAP1 loss. About 2 to 3% of mesothelioma patients may have a genetic loss of this gene that also increases risk for other tumors such as uveal melanoma, renal cell carcinoma. But patients could have loss or reduced expression of BAP1 up to in 60% of mesothelioma patients. It's possible because of the role of BAP1 as a deubiquinating enzyme that drugs such as EZH2 inhibitors or PARP inhibitors may have a role in these patients. And there are other molecular alterations that may potentially guide for certain targeted therapy. So in conclusion, nivolumab and ipilimumab, and I believe even today, despite the impressive results of Checkmate 743, platinum pemetrexed does have a role in patients with mesothelioma patients. Nivolumab should be considered in patients who have received frontline chemotherapy. And multimodality therapy, though we don't have conclusive evidence that surgery and radiation plays a role, that in patients with what one would consider as stage 1 to stage 3 disease, multimodality therapy should be considered, whether with surgery first or following neoadjuvant chemotherapy, it should be decided in a multidisciplinary fashion. Thank you very much.